Good. One more time, keep the knee locked and push. Good. Make sure the knee's locked. Oh, your knee's cold. You've been icing it?
No, I haven't.
Exactly the same. Pull the knees back with you. All right, let's try that again. So bring the leg up, keep the knee locked straight. Don't let me push down. Okay, good. So in this video, we're talking about the mobility aspects to Psoas inhibition, specifically the mobility of the thoracolumbar region. Especially in the situation where Psoas inhibition is recurring, you've adjusted the thoracolumbar junction more than once successfully. Psoas comes back on, but then the next treatment it's off again. You have one of two situations. It's typically either a mobility issue or a stability issue. If we assume that their core strength and stability is good, then that narrows it down to generally a mobility issue, and that's what we'll cover today. So my typical cadence in the office is after I identify Psoas inhibition, I'm going to look to mobility first, because all else being equal, it seems like it's more commonly a mobility issue, at least in the active, relatively fit population. So I'll look at mobility first, and then I'll adjust, and then look at stability after that. So your soft tissue search pattern for Psoas inhibition includes the paraspinals, the spinalis, longissimus, and iliocostalis. Although to be honest, I just kind of refer to them in my charts as medial, mid, to lateral paraspinals. And the serratus posterior inferior, which runs a bit more obliquely. And then wrapping around the side, QL, and the lower half of the obliques. So your target area is anywhere from the top of the iliac crest up to about the 10th rib to the spine. So that's your zone of potential tightness and adhesions. When it comes to iStim tools, I prefer something with kind of a nice broad convex edge, and importantly something that you can do one-handed as opposed to like a two-handed tool. There are many situations in the torso where you're going to be kind of maneuvering around clothes and bra straps, etc. So it's nice to have your other hand free to do that, and also maybe take up a little bit of tissue slack. So I'm not beholden to one particular brand. I don't sell these, but something along the lines of this I find works pretty good. So for the iStim, I like to add a stretch and even a little bit of an eccentric load to the muscle. So I'll have him sitting up. I got the table nice and high for my back. We'll have him bring his arm up overhead, left hand down on the table so you don't push him off the table. Get some lotion on there. All right, and then just kind of round your back forward and left. Not sure if it matters where you start as long as you cover the whole area. Typically your adhesions are most pronounced up around the thoracolumbar area versus the lumbar, but that's not always true, so I'll start top of the iliac crest and kind of work my way up. And in the beginning especially, you're going by sound and texture before you see it. And in his case, I'm starting to pick up on stuff more laterally. It wasn't much medial. Using upstrokes, good cadence. And you can see the petechiae start to develop there. And I'll typically do about, I don't know, anywhere from 5 to 10 passes, and zeroing in on where it's the worst, what you see, what you feel, what you hear. Good, and one more time. So there you go. There's his trouble spot. So for the pin and stretch, I'm basically going to zero in on where it showed up the most with the iStim. Save some workload on my hands. he does the exact same motion. Go ahead, forward and left again, Billy. And I'll use either a reinforced thumb contact or sometimes I'll use my fingers, kind of hook the fingertips into it, trying not to glide, not sliding. I use a paper towel for that reason, otherwise the lotion that you just use for the eye stem won't allow you to stick to your contact. So his, I would call this kind of mid to lateral paraspinals. If it was more the medial paraspinals, it's more likely to include the smaller guys, the multifidi, the semispinalis, the rotatories. If that was the case, I would pin and stretch them as well. I'm going to call this more lateral paraspinal, maybe a little bit of serratus posterior. It seems to be kind of angling vertically, so it looks more like paraspinals. All right, so for the side, for QL and the inferior obliques, we're going to scrape from the side, but again, we're going to include some eccentric load. I'm going to have him bring his leg posterior just off the table and let it kind of drop down towards the floor. So he'll do that. I'll have both my hands occupied up here. Okay, so go ahead and try that, Billy. Leg back and down. So I'll start, again, doesn't matter where you start, but I'll start low in QL, work my way up. That's good, come back up. And again, oftentimes, as with the lumbar paraspinals, there's not a lot in QL. Typically, it's more up around the lower obliques, the lower ribs. Good. And my chart notes last time with him, I indicated that I wasn't finding much. Go again. But I think I may have missed some stuff. A little bit more anterior here. Typically, it's more posterior. But hence, that's maybe why his psoas was back off again, this treatment. Go again. So I'd call this the lower obliques. You can see it starting to show up there. I don't know if you can hear it, but I can certainly hear it and feel it. Good. And just do a couple more. So even this far anterior, you can see the scraper's kind of snagging on something there. Even this far anterior will potentially lock him up at the TL junction. How about two more? QL is sometimes adhesed, sometimes not. Sometimes I think it is adhesed and tight and pulling on things. Sometimes it's just tight, and sometimes, how about one more? Sometimes it feels tight, but after you get the adjustment, most of that QL tension goes away, in which case I think of it as more reactive to the subluxation versus causing the subluxation. Good. All right, so for the pin and stretch for the lateral tissues, you can see kind of where it showed up with the eye stem. So again, I'll zero in on that. In this stretch, I like to kind of hook my elbow into my side to provide the stabilization. Got my other hand assisting his and kind of guiding his leg back and down. A lot of superior tension. Again, using the paper towel so you don't slip. I'll just do two more of these. I always ask in this stretch to make sure that they're not feeling anything pinching or restricting in the lower lumbar spine. By this stage, you should have already adjusted anything in the lumbar spine, but sometimes if they have a subluxation remaining, they kind of slip through, and you put them into this position, they might start to feel that restriction or pinch, in which case you want to go ahead and take care of that before you do too many of these. All right, good. So now that we've covered the mobility side of things, it's time to adjust. And you can check out the Psoas Inhibition treatment video for manipulation.